Okay, let's talk about hypersensitivities and some immune deficiencies. Then we'll go on to infections after this. But I love this picture because you wonder, why are we getting so many peanut allergies? Maybe it's because people are letting their kids play with the peanut butter like this. Who knows? Anyway, so the three stimuli of hypersensitivity are allergy, autoimmune, and alloimmune. When you look at allergies, allergies are exactly what you think about. They're environmental antigens that are out there that are causing some kind of an overreaction. So inflammation and things are normal. Inflammation is good. I actually used to work for a chiropractor that said inflammation is the enemy of healing. And that was not exactly right. You want inflammation. But when it's out of control or over-exaggerated, or you have your immune response overreacting, then it's a problem. So at the point where the immune system starts causing problems for the body, that's when we call them hypersensitivities. So allergies, there's dust and pollen all over us, but when your body starts overreacting to that dust and pollen, then it becomes a problem. That's a hypersensitivity or an allergy. So those are environmental antigens. When you look at autoimmunity, auto of course is self, so it means that you're becoming immune to yourself. You're losing something called self-tolerance that we talked about earlier when we talked about antibodies. So normally you know your own body and your immune system ignores your body and attacks anything that's foreign, but something happens and it changes where your immune system doesn't recognize you as self anymore. It actually recognizes you as foreign and attacks yourself. And then alloimmunity is also called isoimmune, or ISO, which means same. So alloimmunity is when you have a reaction to another person. So it's not yourself you're attacking, it's when something from someone else is in you, like transfusions or grafts, or even from mom to fetus, because they're two totally different individuals, but one is attacking the other. So that's allo or isoimmunity. So just based on those three things, if Sam received a liver transplant, his immune system resisted the new organ, which stimuli of hypersensitivity would that be considered? Right, it would be considered isoimmunity or alloimmunity. So this is kind of a preview slide, and I have a review slide too, but you need to be able to define and describe the four types of hypersensitivities, and there are ways you can look at these. First, type 1, 2, and 3, they're all related to antibodies. If you look at the pictures here, you've got antibodies involved here, antibodies involved here, antibodies, but type 4 sensitivity, there's no antibodies. They call it cell-mediated hypersensitivity. So there are some ways you're going to notice, or some patterns you're going to notice as we go through these. Like, for instance, that type 1 through 3 revolve around antibodies, where type 4 revolves around cells, specifically T cells. So as you're going through this, kind of look for the things that make each of these hypersensitivities a little bit different than the others. All right, the first one, type 1 hypersensitivity. This is what we typically refer to as an allergy. You have an allergic reaction to something. Your body's over-responding to some kind of environmental antigen. And you already know when we talked about antibodies that it's IgEs that are involved in allergies. So this is a specific antibody that's involved. And here's how it works. So you're exposed to something in the environment. Your macrophage, or your antigen-presenting cell, takes it up. It presents it to the B cells. The B cells form plasma cells, which release antibodies into the environment. These are IgE antibodies. Now, I don't think we talked about this before, but the IgE antibody will float along. It finds a mast cell or a basophil, and it will actually bind. So you've got this little Fc receptor area on a mast cell and basophil so that you can load these antibodies into it. This doesn't trigger the mast cell to degranulate. It just sits there. It basically makes it more sensitive to this specific antigen that this antibody is detecting. So it's sitting there. Or it's on a basophil that's circulating through your blood. But they're just stuck to the surface. They're not activated yet. It's almost like you just cocked the trigger on the gun, but it hasn't actually fired yet. Then the environmental antigen comes along, it binds to the antibody, and then that's what pulls the actual trigger. So as soon as the antigen triggers the antibody, these mast cells or basophils start degranulating, and you know the process from there. So you get the endothelial retraction, you get the blood vessels reacting, you get localized edema, the redness, the swelling, everything we associate with inflammation. So that's the mast cell. Remember, the basophil is going to be in here in the bloodstream. And it'll do the same thing, except the basophil will cause systemic response instead of just localized. And of course, you want to remember the key players here. If you're talking about mast cells and basophils, go back and look. Remember, the granules are full of things like histamine. They have some heparin in them. They have chemotactic factors for neutrophils and eosinophils. So go back and look and remind yourself what's going on. All that type 1 sensitivity is, or hypersensitivity is over-response of that inflammatory response we talked about before. So things like antihistamines can actually block these receptors, so that they don't trip on. The antihistamines work better beforehand than after because the antihistamines will actually block the release of histamine. And then, of course, if histamine's causing blood vessels to open up, and it also causes your airway to constrict, what's the name of the chemical in the body that does exactly the opposite? So what autonomic nervous system controller or chemical would reverse the mast cell response? So what can you think of as a chemical that would cause vasoconstriction and airway dilation? I'm hoping you're thinking epinephrine and norepinephrine, right? Adrenaline. So when you see somebody that's having a type 1 hypersensitivity response, an exaggerated one, like maybe asthma, they'll give them something that acts like epinephrine or norepinephrine to cause their airway to open back up. If somebody's stung by a bee, they stab them with an EpiPen to try and cause their blood vessels to constrict so that their blood pressure comes back up. And we'll talk about that when we talk about anaphylaxis in just a few slides. So the next thing you should be able to do is describe how an individual becomes sensitized to the allergen. When we were talking on that last slide, actually I'll go back to it just a second, when you're exposed to the antigen, these plasma cells will start releasing antibodies. Well, the more times it's exposed to this antigen, the more antibodies it releases. The more copies, or the more this proliferates and makes copies of itself. So you get more and more of these little triggers pulled back and ready. You become more and more sensitive. So let me show you how this looks on a graph. For the normal immune system we talked about before, you get exposed to something like a vaccine, your IgMs come out at great amounts, and then slowly your IgGs get a little more abundant. Second exposure, IgGs go out tremendously. But when you're talking about an allergy, it's not the IgGs or the IgMs, it's the what's? It's the IgE. So it's primarily the IgE. So your first exposure you'll have, just like this response before, you have some IgM come out, but then the IgE comes out. And then every time you're exposed to it again, more IgE comes out. So here's your first exposure, second exposure, third exposure. And I heard a story one time about a doctor that was actually stung by a bee, and he had a lot of swelling and everything, but it wasn't fatal. But the second time he got stung by a bee, it was more severe, and he actually had to call an ambulance and get to the hospital. And then they gave him EpiPen, but the third time that he got stung by a bee, he was out golfing, and his EpiPen was in his golf bag, and he actually died before he could even get to his golf bag. So the response just gets more and more severe each time you're exposed to that allergen, so in large amounts. So genetic predispositions, they call this atopy or atopic. It just means that, let's say your mother is allergic to pollen and your dad's allergic to pollen. That means you have a genetic susceptibility to be allergic to pollen. You're just naturally going to be allergic to it. When we were talking about cell selection, and before when we were talking about the thymus gland randomly selecting different MHCs, well, if you have a genetic predisposition to have specific MHCs, then you're going to be more prone to have this disorder. What's interesting is it doesn't carry the Mendelian traits where we can't figure it out using just a Punnett square. If you have one parent that's allergic to something like peanuts, you have about a 40% risk of being allergic to peanuts. If you have two parents that are both allergic to peanuts, you have about an 80% risk. So like I said, it doesn't exactly follow the Mendelian genetics. It's just a little bit different because, and that should be telling you, it's more like either multifactorial or polygenetic. So it may be environment and genes, or it may be multiple genes that are doing it. Here's some ways that we test this. So you can test it by doing a scratch test, where they put the little antigens just underneath the skin, and you can look for a response. And in this one, you can see salines on each of these, but they shouldn't have a response to saline because it's just salt water, and your body's full of saline. But they'll put something, a chemical up here. So here's the regular skin beforehand. They'll put a little histamine in here. Histamine should always react, because histamine, doesn't matter if it's your own or from outside of your body, will cause a response. It'll cause all the inflammation characteristics. And then they'll put whatever they think that you might be allergic to in these other locations. So you've got your control situations, your water, and your normal histamine response. And then they put this allergen underneath you, and they look for a bigger or better response to know if you're allergic to that stuff. So that's one way, skin test. The other way is a RAST. So RAST is where they'll actually take a sample of your blood, they put it on a little disc, they let it incubate, and then they look for a bigger response. This is looking for mast cell response primarily because it's just under the skin. So if they're taking a blood sample, what kind of cells are they looking for a response from? Basophils, right? So they're looking for more of a basophil response. This would be more causing itches and rashes, things on the surface of your skin, where this, they'd be worried about anaphylaxis or shock-like symptoms. So there are 2 ways they can do the test. Actually, there are more than that, but these are the typical 2 ways. So that RAS, by the way, stands for radioallergosorbent test. They just put a little drop of your blood on this little disc, it absorbs in, and then they detect it for antibodies later. Right? And then why can this IG be life-threatening? So what circulating IG are they looking for? Oops, I accidentally pointed to it, but yeah, IgE. And then why can it be life-threatening? Because if this is in your blood and it's being released everywhere, it's releasing histamine everywhere. So what's that histamine going to do to all of your blood vessels? Cause them all to dilate. What's it going to do to your airway? Cause it to constrict. So you have difficulty breathing. Your blood pressure is going to drop dramatically, and they call that shock. Right? So when you think about this, what kind of tissues do you think would be most affected by allergens? And hopefully you're thinking mast cells, the tissues that are just underneath the skin everywhere. And don't think just the outer skin. Think about like inside the mouth. Think about the airway. Think about anything that has access to the outside or immediate access to the outside. It's going to trigger these mast cells. So most of the allergies you'll be experiencing with patients are allergies that are related to outward exposure. I mean, a bee sting actually products under the skin and into the blood. But most things people are exposed to, like inhaling something, eating something, having it poured on their skin or exposed to their skin, that's where most of the allergic reactions are going to be. So when you look, things like rhinitis, that's just runny nose, think about what's happening. They've got pollen that goes into their nose. It's triggering mast cells in their nose to cause the blood vessels to open up. When the blood vessels open up, they get localized edema, which is fluid leaking into their nose. That's going to cause that runny, mucousy, layer. And then it's just that runny nose. And you can see different times of the year you're going to get different responses. So early in the spring you're going to see more of tree pollens. In midsummer you see more grasses, and then late fall you see more of weeds that are causing these reactions. And about 20% of the population actually has some kind of an issue with pollens in the air. And then asthma. So asthma is the same idea. They're breathing it in, they're getting this hypersensitive reaction all the way down their airway. So you have to worry about their airways constricting. But rhinitis isn't such a big deal. I mean, you go through lots of Kleenex, but with asthma, it constricts the airway, causes breathing problems that could potentially be fatal. And then dermatitis, eczema, they're the same thing. Just rashes all over the skin. And we'll actually talk about this more when we get to skin. But if something's exposed to the skin that the person's allergic to, their body will actually react and attack it. And then food allergies like peanuts. Okay. So what are the common clinical manifestations? I actually kind of started talking about this, but when you look at it, you have your allergen that comes in, the mast cells degranulate, they release histamine all over the place, and then histamine causes redness, swelling, edema, itchiness. So they get this itchiness in the area, they get hives all over the area, conjunctivitis, the eye, watery eyes. So everywhere that histamine is being released, you start seeing fluid move out and causes that runniness or that puffiness. So why would it cause hypotension? Think about this. Well, where's that fluid coming from? The fluid comes from the blood, so it's decreasing the blood volume, which decreases their blood pressure. Yeah. And then bronchospasm is because of histamine. Histamine is causing the smooth muscle in the airways to start squeezing up. It shrinks the size of the airway, increasing the resistance, decreasing the flow, which causes breathing problems. And then, of course, GI cramps, malabsorption. This is because, remember, that allergen is exposed to the GI system. It's going to do the same thing. It's going to start causing fluid to move back and forth and irritation to those layers. And, of course, you already know the chemical mediator because this is probably the 4th slide I've talked about histamine. Right, anaphylaxis. So anaphylaxis is a type 1 response. It's an immediate response. And it can be localized. It's like this, angioedema. So angio meaning blood vessels, edema meaning swelling in the tissue or water or fluid in the tissue. And it can be localized to just one area, like if you've seen the movie Hitch, where it's all over his face. When he ate the shellfish, it caused swelling in the lips and the face. Okay. Or it can be systemic and all over the whole body, like with bee stings. So some of the most common causes, or actually if you're under the age of 25, the most common cause of anaphylaxis are food allergies, like peanut allergies or strawberry allergies. I've known people like that too. If you're over 25, it's most commonly bug venoms or medications like penicillin or bee stings or spider bites, things like that do it. Right? So when you think about it, it's immunologically caused. So what are the types of cells that are going to respond or cause anaphylaxis? If it's in the tissues, it's going to be a what cell? A mast cell. If it's in the blood, it's going to be a basophil. Right? So if it's localized, then it's going to be revolving around the mast cells releasing histamine. If it's systemic, it's revolving around the basophils releasing histamine. And of course, what's the antibody? It's an IgE. Right? So this is type 1, immediate. It's not always fatal, but it's always dangerous because if it becomes systemic, it's going to cause airway issues. And then pseudo-anaphylaxis is interesting because you don't have to have like a bee pollen or some kind of an antigen out there. It can actually be because these mast cells and basophils are sensitive to things like temperature and opiates and pressure. So you can smash your hand, and when you smash your arm, it'll still cause that swelling, edema. Some temperature extremes can actually cause the same problems where the mast cells start degranulating. It causes breathing problems. It causes swelling, causes a drop in blood pressure. And then opiates can do the same thing too. But these are pseudo-anaphylaxis because they're not revolving around the IgE being stimulated by an antigen. Right. And then sometimes, anaphylaxis we refer to as being immediate, but sometimes you have something called biphasic anaphylaxis where you get the immediate response, but then you also get a late response or delayed response that could come hours or days later. So let's say you're stung by a bee, you take your EpiPen, and usually it takes more than one EpiPen for a lot of people to respond appropriately. They'll take one, they'll wait 5 minutes and take another one. But then later it can come back. That later response, they're not out of the woods right away, is because of all those secondary factors. When we talked about the mast cells before, remember, we talked about the mast cell degranulating with histamine and a little bit of heparin and a little bit of those chemotactic factors. But those chemotactic factors are still circulating through the blood, so they can keep attracting eosinophils and neutrophils to the area. You've got these late phase chemicals like the leukotrienes and prostaglandins that keep working for hours later. So in the beginning it's because of histamine, but the late reaction could actually be because of all the other chemical factors. Right? And that could last for a few days. So they call it a late phase reaction. Okay, so anaphylactic shock. Putting it really simply, it's step by step. First, whatever that toxin is gets in your body. So in this situation it's the bee venom toxin, or wherever the antigen is. It has to get into the bloodstream. Once it's in the bloodstream, it travels all through the body. So that toxin is circulating around, it's triggering all these basophils and mast cells to degranulate. The histamine is released. If it's systemic, it's opening up all of the blood vessels. They're all dilating. So where's the blood going to go? It goes towards your feet. So the blood rushes towards your feet, causing you to feel lightheaded, pass out. If you're not getting blood to your brain, then of course you're going to die. So it's one at a time. You're also going to see some of those signs like wheezing. Why would they have wheezing? Because the blood carries the histamine up to the airways and causes the bronchioles to constrict. They get redness, they get rashes, they might start getting puffy all over their body. It's the same thing. It's the histamine. Once the histamine gets all over the place, it causes lots of problems. So, but the key here is that their immune system, unless it's atopic, their immune system has to be primed. So they've probably been bitten by a bee more than once in their life. They've been bitten before the antigen presenting cells grab a hold of these venoms and toxins and tell the body this is an invader, make IgEs so that we're ready for it next time, and then you make lots of IgEs. Once that venom comes in the next time, you're more responsive to it. Okay, so how do you treat it? And I kind of talked about this a little bit before. If it's a mild response, so anaphylaxis is not the same as anaphylactic shock. Anaphylaxis is a general category. It can be localized or systemic. Anaphylactic shock is when it becomes life-threatening. So in mild situations, people can take antihistamines to turn down the effect. But if it's something that's potentially life-threatening, of course they want to stab themselves with an EpiPen because you know what EpiPens do. Epinephrine causes your blood vessels to, well, think about it. If histamine causes them to dilate, what must epinephrine be doing? Causing them to constrict. If histamine causes your airway to open up, what's epinephrine do? Or I'm sorry, if histamine causes your airway to close down, what's epinephrine do? Cause it to open up. And if you ever forget that, just think epinephrine is related to the sympathetic nervous system. If you're running for your life, what happens to your blood pressure? It goes up. right? Histamine causes it to drop. Running for your life causes it to go up. What does running for your life do to your airway? Squeeze it down or open it up? It causes it to open it up. So epinephrine is a direct antagonist to what's going on with histamine. Works exactly the opposite. And then the second wave, so after people have that shock, they usually don't just stab them with an EpiPen and leave them alone. They'll give them some kind of a steroid too. And the steroids aren't for a fast response because steroids are slow responding. So when they give them corticosteroids, it's because they're trying to turn off those late phase reactants like leukotrienes and prostaglandins. When you take an NSAID, it's the same thing. Non-steroidal anti-inflammatory drugs like ibuprofen, what they do is they turn off leukotrienes and prostaglandins. Aspirin will do the same thing too. Another way they can do this, and these are of course a response. This is more of a prevention. So they can be desensitized, and desensitized to an allergen is called immunotherapy. So which is one of the types of immunotherapy. So they can get allergy shots. They can actually take very, very small doses orally to this stuff, which I'm going to have you do a little homework on the next slide about the oral desensitization. But here's how it works. So when you take really, really teeny tiny exposures to this antigen, your body will make more IgGs to fight it off. Well, IgGs don't trigger that allergic response. IgGs will stick to the antigen. Your immune system will come in, clean it up, digest it, and process it. Right? It can also turn up some more IgAs. So IgAs, remember, line mucous membranes. So if you eat a peanut, or if you have an egg allergy, if you eat an egg, it binds right away to the IgAs. The key here is that with the desensitization, you're trying to make other antibodies that are not IgE. Because IgE, if you make more of those, you become more sensitive. So basically what they're trying to do is they're trying to get you to make more IgGs, which are the most abundant, so that they stick to the antigen before the IgE can experience it. Because if IgE experiences it, you release histamine. So they call these blocking antibodies, by the way, because that's what they're doing. If this antigen comes in, if it bumps into a mast cell, then you're in trouble. But if the antigen comes in and it binds to an IgG, then the IgG will take it out of your circulation before the mast cell ever even sees it. All right, so the first homework, you're going to go to this link here. It's New England Journal of Medicine, and it's a paper that was written in the last couple of years. And you're going to read about it. But you're going to pretend, in layperson's terms, you're going to pretend that you have a friend that their kid has egg allergies. And what you're going to do is you're going to explain to that person how this paper affects their child. So explain to them what is the allergy, what's going on in their body, just briefly, and then explain to them how they can desensitize to it. You don't have to read the whole article. In fact, this link just gives you the abstract. So what their experiment was, how they tested it, and what their results were. Short and sweet instead of having to read 10 or 12 pages of paper. Okay, so let's see. Do you get it? What's the primary immunoglobulin responsible for type 1 reactions? IgE. What stored chemical is responsible for the clinical symptoms? So the swelling, the puffiness, the redness, the edema. Histamine. Okay, let's go on to type 2. So type 2, this one, remember I told you, it's also antibody mediated, but it's not IgE. So it has nothing to do with IgE. If your IgE is involved, it's always a type 1 sensitivity. So that's an allergy. But type 2, here are the 5 main mechanisms. With type 2, you're going to see that they're all autoantibodies. So what kind of disorders do you think these are going to cause? Autoimmune disorders. Yep, they typically cause autoimmune disorders. And here you can see it's autoantibodies associated with complement, autoantibodies that opsonize, autoantibodies that affect neutrophils, autoantibodies that affect other things like T cells, and then also anti-receptor autoantibodies. So I'll walk through and show you each of these. But those are the 5 main mechanisms of type 2 hypersensitivity. The other thing you want to have written down somewhere is that type 2 hypersensitivity is tissue specific. And those are 2 really important keywords because when you see this react, it's affecting one specific tissue. Like it may be affecting just the red blood cells, or it may be just affecting the pancreas, or maybe just affecting like the liver. So these are tissue specific. They know exactly what they want to attack. Right, so the first type of mechanism. In this situation, you can see that you have the antibodies. The antibodies are attacking the red blood cell because there's something on the surface of the red blood cell. All of your body has MHCs, remember, but but the red blood cells don't. The red blood cells actually will have those little A, B, and O factors that we talked about before. There's some characteristic on every cell in your body that basically identifies you as you. In this situation, it's those little A, B, or absence of A, B, which we call O. So in number 1, it attacks the red blood cells. This is an antibody that triggers complement. Complement sees this and says, hey, we must need to attack these red blood cells. So complement comes along. Remember the whole cascade, C3 and C5 and then C9. And C9 is going to poke in here and create that membrane attack complex and actually lyse the red blood cells. So this is a form of hemolytic anemia is what it would be, but it's an autoimmune version of it. The second one, so here's where it triggers things like neutrophils and macrophages. So here they're more susceptible to phagocytosis. So in this situation, the autoantibodies stick all over something, whatever it is, even in this situation, if it's red blood cells. They stick all over it, and then the phagocytes come cruising along, and they eat that tissue. So they just gobble it straight up. The third one, and this is ideally looking at something like a neutrophil, but the antibodies will stick to the, we'll say, vascular lining here. They stick along the blood vessel lining. The neutrophils smell that this is activated. They come cruising along, and then they'll actually eat the antibodies, but also eat your tissue with it. So tissue specific. And of course, you'd see this if this were attacking blood vessels. You see this occurring all over the body, but specifically to blood vessels, not to the pancreas and not to the stomach. You'd see the blood vessel issues. And you'd probably see it more at the surface of the skin too, because you'd see those blood vessels starting to rupture at the skin. You see all this redness and patchy areas. Right. The fourth type, so type number 4, this is where it triggers natural killer cells. So the antibodies bind, they trigger the natural killer cells to come along and destroy whatever that tissue is. So let's say that here's the tissue. The tissue gets bound by an antibody. Your natural killer cell comes cruising along, it sees the antibody, it doesn't matter that this is you, this could be myelin sheath, so maybe it would be triggering MS, multiple sclerosis. It sees this antibody that's stuck accidentally to the myelin sheath, it comes along here, and it binds to the antibody. So the NK cell binds to the antibody and starts spitting out the lysosomes. So it's spitting all over it and digesting the enemy, which is actually you. And then the last one, in this situation, you get antibodies that bind to specific types of receptors. And this is going to be something you'll see when we talk about myasthenia gravis in the muscles. We'll also talk briefly about the thyroid having this problem. So, in this situation, the antibodies come along, they recognize a receptor, they bind to the receptor, and the biggest problem here is that now, since these antibodies are in the way of the receptor, the neurotransmitters or the hormones can't bind. So if this receptor was important for muscle contraction, now this neurotransmitter can't bind, what's going to happen to the person? They can't contract the muscle. So here are a few examples. One, like I already mentioned, autoimmune hemolytic anemia. In this situation, you see that the autoantibodies actually turning on the complement, and the complement's destroying all these red blood cells, and then they're starting to clump together. So they come in, they bind, they destroy, and then they clump. Right? Sometimes you'll see this with like penicillin. So penicillin kind of triggers this response and causes it to start binding. Type 1 diabetes is another example, tissue specific. So in this situation, the antigen that's recognizing is on your islets of Langerhans, which make insulin and glucagon, but if it's looking like at the insulin cells, then your antibodies come along, they bind to the insulin-producing cells, and I don't know if you remember from anatomy and physiology, so that would be the beta cell, and then it's going to start attacking all those beta cells until it kills them all. So even if you brought it back or you did a transplant, those new beta cells that are there, they're still going to get attacked by that person's immune system. So of course this is type 1 diabetes, it's attacking the pancreas. But you can have the same problem with type 2. So you can actually have insulin receptors that are being attacked by antibodies. Another problem, Graves' disease. So with Graves' disease, this is kind of interesting because instead of destroying the tissue or turning down the tissue, the antibody actually acts like thyroid stimulating hormone. So it acts the same. So, here you have the thyroid, so thyroid tissue. Normally you have thyroid stimulating hormone that comes down from the anterior pituitary, binds to the thyroid and tells the thyroid make more T3 and T4. So then it makes more T3 and T4. But here's the problem is that these thyroid stimulating immunoglobulins, which are looking like thyroid stimulating hormone, will come down from the B cells. They bind to the thyroid, to the same receptors, and they tell the thyroid make more T3 and T4. So it turns up the thyroid production. It's not destroying the thyroid, it turns it up. So another problem here is that this thyroid stimulating immunoglobulin will bind to glycoproteins behind the eyes and start causing them to bulge out too. And this is called exophthalmos. And you've probably seen like Rodney Dangerfield had exophthalmos, and Marty Feldman, the guy that was in Young Frankenstein, he had exophthalmos. But if you remember your physiology, T3 and T4 turn up metabolism. So what would happen to these people if they were receiving too much of this thyroid stimulating immunoglobulin? Well, their metabolism would go up. They start losing weight. They feel really hot all the time, so they call that heat intolerance. But the problem is it causes muscle weakness and some menstrual irregularities too, because of where these immunoglobulins bind. And then myxedema, looks like mixed edema, is pronounced myxedema, is swelling and puffiness around the joints. Right, so the second homework question is you're just going to plug in the correct parts here. So I've labeled each of these 1, 2, 3, 4, 5, 6, 7, 8. All you're going to do is you're going to take these phrases and plug them in the correct order. So you can see here alteration of specific tissue antigens on the host. So in something like this, something's changed. Maybe they were exposed to some kind of virus or some kind of a bacteria that looked a lot like a thyroid receptor. Something changed this antibody, and now it binds to this specific tissue. What's it going to do from there? So take all those pieces and plug them in. So what different responses is it going to have? And then what would be the final outcomes in this situation? So this situation I gave you Graves' disease. Okay. And then I know it's 2 homeworks right back to back, but here's a second one. So in your own words, describe the 5 mechanisms of type 2 hypersensitivity. So you can use your book, you can go online and Google it, you can use the lecture video, you can do whatever you need to, but they have to be in your own words so that you remember how it affects each mechanism. All right, type 3. So type 3 hypersensitivity. Type 1, remember, was IgE related. It's called an allergy. Type 2 was tissue-specific antibody mediated. Type 3 is what I like to think of as being accidental. So it's an accidental. It's still because of the antibodies. The antibodies are circulating through the system, and then they bind to an antigen, they get heavy, and then they stick to things. Well, if this antibody accidentally sticks to the wall of a blood vessel, then when the macrophage or the neutrophil comes along to clean this up, it accidentally eats your tissue with it. It's not targeting it like in a type 2. This is an accidental. So you've got these antibody complexes, they call it antigen-antibody complex, where the antigen and antibody stick together, and then they stick to the wall of a blood vessel. Well, then your macrophage comes cruising along, or your neutrophil comes cruising along. It eats the antibody, but it accidentally eats the blood vessel with it. And that causes a lot of problems. So this is not organ-specific. It's a total accident. This is actually another one that you see something unique. You get hypocomplementemia with this too. And the reason is because you have all this complement being activated. It actually drains your complement reserves. It's the only of the 4 hypersensitivities that cause a lack of complement. The other ones increase complement, but this one actually uses all your complement up faster than you can make it. So it causes hypocomplementemia. Sometimes they call this frustrated phagocytosis too, because these phagocytes are just eating everything. Anywhere that this antigen antibody binds, it just goes crazy and eats things. So another thing you'll see different between type 2 and type 3 is type 2, it's usually one specific tissue, one specific organ that's being attacked, where in type 3, it's all over the place. It's very generalized. So here's just an example again. You've got this complex that comes cruising along. It binds to the wall of a blood vessel as an example. It could bind to a tissue too, but another type of tissue. But it binds here, and then your phagocytes come cruising along and they eat it up. And then a couple examples, serum sickness and Arthus reaction. So these affect blood vessels. when you have serum sickness, the reason they call it that is because back in the older days when they'd give somebody a vaccine, they would give them the vaccine, and it may have some horse serum in it, or it may have some goat serum or some other animal serum in it, and then the bodies would react to that. Because that serum would contain antigens, their antibodies would stick to the antigens, and it would accidentally stick to the blood vessel walls and cause redness, swelling, irritation, and the destruction of the tissue. So serum sickness is, well, traditionally it's because if you took serum from another animal, but nowadays it doesn't matter. So here again, Arthus reaction is just another fancy name they gave for it. It was named after the scientist that discovered it. But the scientist, Dr. Arthus, what he did is he would take, I think it was goats and horses, but he would take horse serum, and it was rabbits. He'd put horse serum in rabbits, and then the rabbit's immune system would start attacking it, sticking to their blood vessels, and then the rabbits would actually die because of necrotic tissue. It would start eating their blood vessel walls, the blood circulation wouldn't work anymore, and then they would die because of it. So it's called serum sickness or Arthus reaction. And one more thing you might want to jot down is that usually it's because of middle-sized antigens. If you have a large antigen out here, it's really easy for the macrophage to identify this large antigen, clean it up, and be specific about it. If you have a really small one, a lot of times these antigen-antibody complexes can slide through the kidney and you can just clear them. But the problem is it's the middle-sized ones, the ones that are too big to be urinated out through the kidney, and the ones that are too small to be easily recognized by the neutrophil. So they stick to the walls. So it's usually the middle-sized proteins that are causing the problems. And sometimes you hear this reported after vaccinations. So here are the two most common times you'll hear about is membranous glomerulonephritis. So it's attacking the membrane of what organ? Glomerulonephritis. The glomerulus and the nephron of the kidney. So remember, the kidney can clear really teeny tiny peptides, not big proteins, but those teeny tiny peptides can slide through. The problem is if you get a bunch of these stuck together, then they can start blocking up the kidney. And here you can see along the wall of the glomerulus, so here's your Bowman's capsule around here, here's your blood vessels in the glomerulus. You can see all these dark antibodies accumulating around here. Right. Here you can see normal, there's your Bowman's capsule, they're all of your glomeruli. And here you can see how dense and thick all those antibodies sticking are. So nice and clear and thin, very dense and thick. It's basically like taking a spaghetti strainer and trying to push a bunch of rice through the spaghetti strainer before you put the spaghetti in. It clogs it up and causes problems. So in about 40% of the cases, it actually causes renal failure. Next one is Raynaud's syndrome. And Raynaud's is actually because of globulins that change when their when their temperature exposed. So cryo means temperature. And it's a form of serum sickness. What happens is they have these immunoglobulins that are circulating, and when their hands or their feet get cold, they start sticking to the walls of the tissue. It's not tissue specific. It could be blood vessels just sticking to tissues in general. So when their fingers get cold, all these antibodies start sticking along their blood vessels in their fingers, and it causes decreased blood flow. So you start seeing pallor or bluish colored, so cyan, so cyanotic tissue. And these are all not photoshopped, these are all real pictures. So in cold temperatures you might see it turn completely white, a little off-white. Here it's actually turning blue at the fingertips. So that's Raynaud's. It causes blood vessels to get blocked. Type 4 hypersensitivity. So with type 4, this is totally different than the other three because this one is called cell-mediated. You actually have to have the cells present for this to work. And it's because of the T cells. So the other three required antibodies. This one doesn't. Right. So what happens is another thing they call this is delayed hypersensitivity. It's the whole immune response. So you have this antigen that's present on the skin. It turns on the dendritic cells or antigen-presenting cells that send a signal or basically go to the lymphatics and say, hey, there's something out here, come get it. And then your T cells come to this tissue and they start attacking the tissue that's holding whatever that thing is. So let me show you an example. Poison ivy. So poison ivy have little chemicals, little molecules in the poison ivy that are antigens. Well, they're lipid soluble, so they go into your skin, but then as soon as they find skin proteins, they stick to the proteins. So here's the antigen, here's your collagen, and what happens is this will stick to the collagen and now they bind. Now that antigen's actually on your tissue. What happens is the dendritic cells recognize the antigen, they talk to the T cells, and then the T cells will send cells down and start attacking that tissue. So you're going to start eating away at the tissue. You're trying to destroy all this collagen. Well, the collagen makes your skin, so you end up destroying the skin. But it's actually really dangerous. It's not a fast, immediate reaction that happens in 5 to 10 minutes. Think about it. Poison ivy, people are out playing baseball, they're playing in the woods, they're doing whatever, and then the next day when they wake up, then they start scratching and itching, and they see that response. Right? So within 1 to 2 days, you're going to start seeing a little bit of that swelling, itchiness, the redness, and then what's going to happen is the tissue is going to be eaten away. So here's what it looks like. There's the redness, the itchiness, and there's the site of infection. So the body actually came through here and ate all that skin. It destroyed all that skin. And of course, the big risk here is that now you've destroyed the skin, you leave it susceptible to other infections too. Right? So here, remember, it's not IgE mediated, it's not antibody mediated, it has nothing to do with tissue specific. You could eat the poison ivy and it would affect everywhere, through your GI tract, your respiratory tract, everywhere. So it's not tissue specific. And I gave you poison ivy as an example, but there are a lot of other things like nickel. I know my grandmother was allergic to nickel, so they put nickel in a lot of jewelry, and she couldn't wear cheap silver because it had nickel blended with it. She had to have more expensive silver jewelry, otherwise her body reacted to it. Some cosmetics that cause people to puff up, rubber products like, of course, when you're talking about nylon, like surgical gloves, when people have latex reactions. And then you can see the symptoms, and I kind of explained this to you already, but that invader gets into your tissue, it binds to your actual tissue, and then your body has to come up, clean out the invader, but it has to destroy your own tissue in the process. So here are a couple examples of delayed hypersensitivity. Like when you get a TB shot, they take a little injection, they put it underneath your skin. It doesn't show up right away. In fact, they tell you to come back 24 to 48 hours later. And what will happen is that if you have antibodies in your system, your immune system will start reacting. It takes a little bit more time. But then you get that big bubble, nasty, irritated area. Hashimoto's thyroiditis. So we talked about Graves' disease. Graves' disease causes increased activity of the thyroid. Hashimoto's causes destruction of the thyroid. So what's happening here is that something got in this person's body that looks a lot like thyroid tissue. Actually, thyroglobin, which is a precursor to thyroid hormone. So it gets in their body does a normal response, antigen-presenting cells take it, they expose it to T helper cells expose it to the B cells, and the B cells and T cells will start doing their job. So the B cells will release antibodies, the T cells will actually attack the tissue. Well, unfortunately, this tissue in your body looks like whatever that invader was. So now the T cell starts attacking that tissue. And then it starts sending out warning responses to all the other T cells and says, hey, here's the invader right here, come get it. So here's normal thyroid, and then here you can see that the thyroid is just totally inflamed in the situation. So it destroys the thyroid cells. So what would you predict the symptoms? If hyperthyroidism, or when we talk about Graves' disease, turned up metabolism, caused weight loss, caused excitability, caused heat tolerance, what would you expect to happen to Hashimoto's? Well, they get weight gain, a lot of puffiness in their face, right? Maybe a little bit slowed down, their metabolism would be turned down, their temperature, they'd feel colder a lot more often. Yep, their metabolism would start shutting down. So here are just a couple examples. Graves' disease, we saw this before. The immunobodies, they bind and they turn up. They hyperactivate the thyroid. They don't destroy it, they make it more active. You can actually get a goiter from this because the goiter, your thyroid is getting so active, it's swelling, getting bigger, to make more thyroid hormone. Hashimoto thyroiditis comes in, stimulates B cells and T cells, and the T cells come in and they actually destroy the tissue. Right? The antibodies can come in and they basically sensitize your body to that tissue when it wants to eat it more, but T cells are doing the damage. So there's a huge difference between the two. One turns up activity, one destroys the activity. One's antibody mediated, one's actually T cell. This CTL is cytotoxic T lymphocyte, which is a T cell. Right. And then hypersensitivity review. Just go through, and I put some notes here that help me remember what the different ones are. So IG1, 2, and 3, remember antibody. IG2 had those special mechanisms, and it's tissue specific. IG3 is an accidental, which I didn't write on here, but it's an accident. So antigen-antibody complexes accidentally stick all over the place and cause problems. Right? And then type 4s, a lot of times you'll see it associated with alloimmunities and autoimmunities. But in reality, autoimmunities can come from type 2, 3, or 4. Right, and then the last section here. So define autoimmune diseases, give examples of the causes. Autoimmune diseases that are true autoimmune diseases are either type 2, 3, or 4. And the whole point of this is that you've lost tolerance to self. Your cells, your immune cells, they don't recognize you as being self anymore. They recognize you as being foreign. So they try and attack you. They try and kill your tissues. And there are a couple mechanisms down here that you can see that cause it. One's breakdown of tolerance. It just means that the body recognizes self-antigens as foreign. So that's just a simple term. Another one's called sequestered antigen. And in this situation, your self-antigens, normally they're not seen by the immune system, like in the brain or for boys in the testis, because remember, they don't make sperm until they're 13. So the immune system, when it was developing, it never saw sperm before. So what happens now is that, whoa, there's sperm in the body. If that sperm is exposed to the blood in the immune system is going to want to attack it. And that's called sequestered antigen. And that's what they call the brain and the testis immunologically privileged, because they're privileged where they don't have the immune system going through them. So there are disadvantages too, because it's more susceptible to infection. But the good side is that you don't attack your testis and you don't attack your brain tissue normally. Right? The next one is infectious disease, or what they call cross-reactive antigens. A really common one is actually Epstein-Barr virus, and we'll talk about this when we talk about the nervous system in the coming weeks. I don't remember if it's next week or the next week, but if you have a cross-reactive antigen, what happens is it comes over and they call it molecular mimicry. It starts making your body think, well, geez, this looks like a tissue in our body, but it's an infector, so we're going to attack the infector, and then suddenly it realizes, well, the infector's gone, but these tissues in our body look like that infector, so let's go get them. And they think MS is actually related to this cross-reactive antigens or molecular mimicry, because they think Epstein-Barr looks enough like myelin sheath that when your body gets rid of the Epstein-Barr or attacks the Epstein-Barr, then the Epstein-Barr is gone, it starts attacking your myelin sheath instead. The next one, neoantigen. So neoantigen is just when one of those little haptens actually becomes immunogenic. Remember, haptens are so small, they're not normally triggering the immune response, but sometimes those haptens will actually bind to one of your tissues. And so you start recognizing your own tissue as being this invader hapten. And then forbidden clone. Forbidden clone, remember when we talked about selecting a while back, where your body makes all of these cells that make antibodies, but any of them that recognize self are destroyed. Well, what if one of those clones actually got out? It could replicate out in your body and cause lots of problems, and they call it forbidden clone. So when you've lost that selective ability and one escapes, then your body attacks yourself. And then ineffective peripheral tolerance. Ineffective peripheral tolerance and genetic factors, I think we talked about before, like when we talked about atopy and atopic situations. So the genetic factors is because of the HLA, the MH. So in this situation, let's see if you got that. So rheumatic fever occurs following strep infection. So you've got this cause. You've got strep that gets into your body. It causes your immune system to go crazy. But then when the strep is gone, then your body starts attacking your own tissues. And it actually goes for the skin and the heart valves. So rheumatic fever can cause scar tissue to build up on the heart valves. And of course, when you cause problems with the valves, then you cause problems with flow. But the syndrome in general, you get a lot of inflammation, you get joints that swell, you get the heart valves that are inflamed and become scar-like. So what is it? What of those pathways back here, these mechanisms, which of these mechanisms is that? So is it breakdown of tolerance, sequestered antigen? Is it cross-reactive antigens, neoantigen, or was the genetic factor? Well, if you're exposed to an invader and then your body starts changing after that, it's called cross-reactive antigen, right? Or molecular mimicry is the other term that I use, and a lot of times you'll hear that one most commonly. Right. And then autoimmune examples here. So systemic lupus erythematosus. And this is multisystemic. Usually you see it primarily at like the joints and the blood vessels though, but it's all over the place. And what happens is you have autoantibodies that start attacking nucleic acids or erythrocytes or basically complement proteins. They start attacking everything and just go crazy. So you have these circulating antibodies that go through your system and they start blocking things up, clogging things up. So it just creates this cascade. And if you watch House, they're always like, oh, it could be this, could be that. It could be lupus. But in this situation, it happens more commonly to people that are 20 to 40, and most commonly females. It's about 8 times more common in women than men. And even in pregnancy, it's about 15 times more common in women. I was about to say than men, but yeah, men don't usually get pregnant. But yeah, it's about 15 times more common in pregnancy. Right? And there's a lot of theories on what's going on. They think there are a lot of other causes too, but they think that the biggest cause of this is actually a dysfunction in those T suppressor cells. So your immune system is just kind of going crazy. It's overreacting because the suppressor cells aren't working appropriately. So here are some of the symptoms. You can see for about 90% of the people that get lupus, they have types of arthralgias or arthritis. So arthralgia means pain in the joints. Arthritis, of course, is swelling in the joint. Vasculitis and rash, remember, joints and blood vessels are the primary keys here. But you can also have renal damage or blood vascular damage and cardiovascular damage, just lots of problems. And about 50% of these people will get something called a butterfly rash that looks kind of like this. So butterfly rash in the cheeks. But you can see all these physical symptoms of the skin that are happening. The way that the diagnosis is that, well, there are 2 things you have to do. First, you have to have 4 of these symptoms. So either blood disorders or neuro disorders or sensitivity to light or the rash, but they have to have 4 of these, and then they have to have ANAs, which means anti-nucleic acid antibody or an anti-DNA antibody. So this attacks the nucleic acids in your body. Remember, DNA, RNA are nucleic acids. So if those leak out of the cells, then your body starts attacking them. So anti-DNA, anti-nucleic acid antibodies. So 4 of these symptoms plus that antibody circulating. So if you're, well, let's see if you get it. So Mary has SLE, systemic lupus erythematosus. Her doctor said this is a hypersensitivity disorder. Which one would it be? So this gets a little bit tricky, and that's why I put this on here. So which one would it be? Does it just attack one specific tissue? Or does it attack lots of things? If you look from this example, remember, you have all this clumping, this clotting, and it sticks to the walls here. This is just like an accidental accumulation. You can have specific anti-nucleic acid antibodies, but nucleic acids are in every tissue of the body. So what would it be more of? Would it be more of a type 2 or a type 3? Well, we know it's not type 4 because that's cell-specific, cell-mediated. Type 2 is tissue-specific, so it has to be type 3. And it's because of these immunocomplexes that are accidentally sticking everywhere. So they get symptoms all over their body. Right? And then the last homework for this section, homework 4, scleroderma. It's progressive systemic sclerosis. So they have this scar tissue all over the body. And you can see what's happening is that their body's attacking their tissues. And you're looking it up. You can see this destroying the tissue. Poor circulation. They have these glassy fingers. And what's happening is that they're accumulating a chemical. And I want you to look up the chemical. What's the name of the chemical? An ion, a mineral. I'm trying to get more and more specific so that you don't accidentally find some obscure chemical out there. But an ion, a mineral, it's the same thing. It's accumulating here, making it look glassy. Right? So what is it? Who gets the most? What age gets it the most? Oops, that got covered up. And then what are the typical symptoms? But definitely look at the ion or the mineral that's involved here too. Right. And then define alloimmune. So allo, remember, is also known as isoimmunity, and it means it's the same organism. So you get it from another person, basically. People that are going to get this are people that get transplants or blood transfusions. Those are the typical people getting it. And we're going to talk about a couple of examples. So first, you need to remember how blood works. Right? So with transfusion reactions, There are actually over 80 red blood cell antigens, but we grouped them into A's, B's, and then RH. So you either have the antigen for A, the antigen for B, or the RH antigen. And there are different combinations too. So if you have type A blood, that means you have the antigen for type A. You make an antibody that fights type B, so you can't get type B blood in you. If you have type B blood, you have an antigen on your blood cells that's B. So you make a type A antibody that attacks type A blood. If you have type AB, you have both A and B antigens, which means you cannot make an antibody, which means it's perfect for you because you're the universal recipient. You can receive type A, type B, and you are just fine. And then type O blood have no antigens, which means they make an antibody against A and against type B. So definitely go back and refresh yourself with that. That's something that was covered in anatomy and physiology no matter where you took it. So this is just another slide that shows you the different situations. And there's a game down here if you want to type this, or you can just go to Google and type blood typing game. It walks you through. It's kind of fun. I think like the first 7 or 8 links are all the same game. So if you just type blood typing game into Google, you'll find it. Alright, so here are the disorders that are associated with this. Alloimmune hemolytic anemia. So in a transfusion, or actually across the membrane of the placenta, it could do it too. But this is not the same as autoimmune hemolytic anemia. The symptoms can be very similar, but this is alloimmune, which means that you're getting it from either transplant or from mom across the placenta. So in this situation, what's happening is they have decreased hematocrit, they accumulate bilirubin, and you see this more in babies and infants. So the Coombs test, or the Coombs positive test, when Genevieve was born, I actually had not heard of that, and it drove me nuts because I talked to several nurses and nobody could explain it to me. So I'm explaining it to you. So here's what happens. And by the way, this most commonly happens in type O moms. So you've heard of getting tested for RH if you're a mother to make sure that the baby's blood and the mom's blood are compatible. But even if baby and mom have the same RH, if mom's a type O blood and baby gets a different type blood from dad, there are some antibodies that can actually get into the baby's system and attack it. So here's a situation. Let's say this mom's type O, dad's type A, and so baby's type A. So baby's type A, negate the RH factor for now. What can happen is that mom's antibodies against the A can slip across. And once they slip across, or during pregnancy with the lots of bleeding, those type A antibodies get to the baby's blood and they start sticking to the baby's blood. They can cause it to coagulate, clot up, or clump. Well, a big problem with this is that babies, their livers aren't super efficient yet. So if you get a lot of these red blood cells that clumping or clotting, and then the problem is that when you break down red blood cells, you make lots of bilirubin. So they get more jaundice in this situation. So the cause here isn't because of the RH factor. The cause here is typically because of some of these antibodies that mom makes that accidentally get across. And then they call it the Coombs, or direct Coombs or indirect Coombs. And a direct Coombs is when they test the person's blood directly. Indirect, like in this situation, it would be babies. In this situation, it would be mom's blood being tested for it. But you can do the same thing with hemolytic anemia. So people that are hemolytics can have that problem too. And then here's how the antibodies get across. So this is the RH situation. So there are actually 5 antigens for RH, but we just refer to it in general as RHD. So let's say that mom is RH negative. She doesn't know what that RH thing is on the blood. Baby's blood, baby got RH factor from dad. So baby's blood has RH. Well, the good thing is that the blood never swaps for the first baby until birth. There's a chance that the blood could be exchanged between mom and baby during birth because of all the labor. Well, in this situation, mom doesn't know what this is. Her immune system's patrolling, just wandering around, doesn't know what the baby is in there, and just cruising around. Well, during birth, if baby's blood meets mom's blood, now mom says, what's this RH stuff? She'll start making immune complexes against the RH. So this baby's out of the woods. It's slid out. Mom's immune system's not going to attack it. But the next baby can. The next baby has RH factor plus. Mom has antibodies against it, which are type G. Type G antibodies, remember, can get across the placenta. So they slide across the placenta, and they actually bind to the baby's blood. and it causes erythroblastosis fetalis. It's destroying the baby's blood is what's happening. This typically happens in the second, third, fourth baby, everything after the first baby. But it causes hemolytic anemia, and it can actually cause death in utero, or it can cause severe anemia or jaundice or shock in the neonates. Oh, I guess I could tell you real quick. So what they do to prevent it is about 72 hours before mom gives birth to the first baby, they'll give her huge doses of something called Rogam. And Rogam, they put it in her body, and it sticks to any of these Rh factors that get into mom's blood. So remember when we were talking about desensitization, how you're trying to make lots of blocking antibodies? Well, that's what Rogam does. Rogam gets into mom's system for 3 days. Basically, they're really doping her heavy in these chemicals that fight the Rh factor. So if baby's born and slips a little blood into mom's system, these Rogam will bind to the Rh factor so that mom's immune system never sees it. So that hopefully the next time she has a baby, it's like the first baby again, where she's never been exposed to that Rh factor. And here's another problem. It's not just the blood, it can also be other blood cells, like thrombocytopenia. So here's neonatal alloimmune thrombocytopenia, where thrombocytes are being attacked. So remember, thrombocytes are there for blood clotting, and in this situation, the baby gets lots of little papules all over its body because it can't clot blood. So anywhere these little blood vessels burst, normally they're clotted, they're healed, and you don't see this. But in this baby, you can see all the little red bumps all over because the thrombocytes were not working. Right? And then the last one, graft rejection. So this is another alloimmunity. When you get an organ from your sibling or from somebody on a transplant list, you can get rejected. So, and it's because of those HLAs and MHCs we talked about before. So the MHCs are sitting on your tissue because of the HLAs. And what happens is that the new person, the host, the new person can reject the person that donated its organ. So I had a total brain fart for a second there. But here you can see that they put the new organ in. You can have acute rejection. Acute rejection is usually within the first couple of weeks. So let's say they put it in, they seem like they're doing fine, and then in a couple of weeks they start losing it. So about 20 to 40% of people will still lose it with the immunosuppressive drugs, but 100% lose it without the immunosuppressive drugs. So if you get the organ and you don't take some kind of immunosuppressant, it'll start attacking the organ. You can see all of the bleeding areas, all the whitened areas here from hypoxemia that's destroyed the kidney. And then about 50% of all the people that have transplants will actually have a rejection within 10 years. So that's considered chronic if it takes that long. So if it's within a few weeks, it's acute. If it's years down the road, then it's considered chronic. Hyperacute's really rare. Hyperacute, as soon as you put the organ in the person and they increase the blood supply, so they turn the blood flow onto the organ just turns white. Because what happens is the immune system starts attacking it right away. It blocks up all that blood flow and creates the white or pallid tissue. So hyperacute's rare because for hyperacute to happen, they would have had to have exposure to that person's organ before the transplant. Because their immune system is responding because of the past experience. Right? And then this last thing, graft versus host disease. Graft versus host means that if you put a transplant into a person, the host, that's the person receiving it, if you put that into them, but their immune system is extremely compromised, they have HIV or SCID or anything like that, their immune system is already compromised, if this new organ going into them has healthy immune cells in it from the donor, then what happens is this person's immune system will be attacked by the new organ. So this immune system that was hiding out in the kidney gets into that person's body and starts attacking them. What's even worse is that because this is an immune system, it starts releasing cytokines, which turns up their own immune system and just causes increased response. So graft versus host disease happens to people that are immunocompromised, and then the transplant just gets rejected. So here's just an example too of transplant rejection. So they did a skin graft, and this person's body, you can see how pale it is rejecting it. It's isolating off the blood flow to it and trying to kill that skin because it considers it an invader. And that's everything for hypersensitivity and alloimmunities.